Many thanks for inviting me to speak today. I'm going to present to you 3 challenging head and neck imaging cases that I have seen during my time here while working at East Sussex Healthcare Trust. And for those of you who I haven't met, I'm a consultant head and neck and neuroradiologist working here at the Trust. So, the first case, right on into it. This is a 60-year-old Caucasian female patient who presented after a recent cold with a background history of autoimmune thyroiditis, but euthyroid. She presented to emergency with rapid neck swelling, dysphagia, and chest pain, which radiated to both shoulder blades. On examination, there was bruising over the neck and chest wall, but no stridor. She was admitted for further investigation and monitoring. A nasolaryngoscopy showed only mild pharyngolaryngeal swelling. Bloods were taken, which showed an elevated calcium and parathyroid hormone level. The CRP and ESR were mildly elevated, and the hemoglobin level was mildly reduced. And the remaining bloods were normal. So the initial imaging that was performed was an ultrasound, a CT, and an MRI scan. This is an axial slice of the CT scan, which shows this nonspecific edema and swelling here within the pharyngeal mucosal space extending down into the hypopharyngeal region. When we gave contrast, we could see that there was this spherical enhancing focus within the visceral space. Can I just ask everyone to turn off your microphones, please? We're just getting a bit of feedback. Is anyone else hearing a background feedback there? It's a bit better now. Okay, so carrying on. There was a ring-enhancing focus within the visceral space on the left-hand side in the paraesophageal region when contrast was administered. We then went on and did an MRI scan, and this is a sagittal T2 weighted sequence, and what you can see immediately is that there is a fluid level within the pharyngeal mucosal and visceral space here, really extending in the paraesophageal region inferiorly. When we apply fat saturation to the sequence, you can appreciate all of this edema and bruising and swelling extending out from this visceral space towards the supraclavicular fossa on both sides, which was what was visible on clinical examination. On the pre and post-contrast T1 weighted sequence, again, we're able to appreciate that there's this ring-enhancing focus in the left paraesophageal region. An MRA study was performed to exclude any kind of dissection or aneurysm, pseudoaneurysm, which was negative. So what happened? The patient remained stable on admission and was discharged home with advice. Follow-up imaging was arranged in 5 weeks to try to hone in again on the identifying underlying cause. What we then performed was an ultrasound of the neck, and what we could see was in the retrothyroid region on the left, there was an oval hypoechoic shaped focus which demonstrated a polar vessel. The follow-up MRI neck scan at 5 weeks showed complete resolution of the retroesophageal hematoma fluid level. And when we applied the pre and post contrast study, we could see that there was still a ring enhancing focus, slightly less prominent on the current study, but still present in the left paraesophageal region. A technetium-99 sestimidi study was also requested, and that showed that there was a focus of increased uptake at the same position that we saw the ring enhancing focus in the left lower anterior neck. So the differential diagnosis for a patient who presents with a spontaneous retroesophageal hemorrhage would include benign vascular malformations, lesions of the thyroid or parathyroid gland, primary or secondary neoplasms complicated by bleeding, ruptured aneurysms, fasciitis or underlying trauma or coagulopathy. So the diagnosis in this case, given the imaging findings, was a retroesophageal hemorrhage from a parathyroid adenoma, which had ruptured, possibly cough-induced. Retroesophageal hemorrhage from this diagnosis is quite rare, and there are only 20 cases in the reported literature since 1930. It's a potentially life-threatening condition due to airway compromise or hemodynamic instability. It's presumed the result of necrosis and angiogenesis within the rapidly enlarging parathyroid adenoma. Capps first described in 1934 multiple parathyroid tumors with massive hemorrhage in this article, and he describes Capps' triad for the manifestations of hematoma at this location, including tracheal and esophageal compression, anterior displacement of the trachea, and subcutaneous bruising over the neck and chest wall, which was very well delineated on our fat-saturated T2-weighted MRI sequence. Nyland's classification describes the findings you would encounter in cases of parathyroid apoplexy, and there are 3 grades. If the adenoma has necrosis, whether the hemorrhage extends inside the capsule or beyond the capsule determines the severity of the clinical features, and in the last case, where it breaches the capsule, the patient can be rendered normocalcemic. So our patient went to surgery to have excision of the parathyroid adenoma. It was found to adhere to the wall of the esophagus just deep to the recurrent laryngeal nerve. She had a transient laryngeal nerve palsy after the excision, but this resolved completely and she remains well. So in summary, spontaneous retroesophageal hematoma can pose a diagnostic dilemma in the absence of predisposing factors. A parathyroid-related cause of retroesophageal hemorrhage is very rare, but should be considered when the parathyroid hormone and calcium levels are increased. Always assess the patient for signs of shock or airway compromise, and it was the correlation of multiple imaging studies that enabled us to reach the diagnosis in this particular case. What I'd like to do is now progress on to the second case, and if you could just make note of any questions you have, if we can ask the questions at the end, that would be really helpful. So case number 2. A 66-year-old female presents with a 24-hour history of rapidly increasing lower anterior neck swelling with overlying skin erythema, pyrexia, and neck pain. On examination, there is visible swelling at this location, and the area was tender on palpation, but there was no stridor. She was admitted for investigation and treatment. Nasolaryngoscopy was completely normal. Her CRP and white cell count were both elevated, but all other blood results were normal, including TSH. The imaging investigations performed were ultrasound and CT, including biopsy. These are axial CT scans with contrast, which were performed at the level of the hypopharynx and at the level of the thyroid. You can see that there's a very large room-enhancing collection here, which extends from about the mid-anterior neck at level 3 down to involve the left lobe of the thyroid gland. It bulges the strap musculature, and there's overlying subcutaneous fat stranding. It would be compatible with an abscess. When you look carefully at the level of the hypopharynx, there is a very narrow channel of enhancement with fluid which tracks towards the piriform fossa, which is collapsed. On the ultrasound, we could see that there was a complex collection containing debris. This was aspirated, which yielded frank pus, but no specific growth of a pathogen was identified. A core biopsy was then performed across the wall, and this identified purulent material with severely inflamed granulation tissue, which was consistent with an abscess, but no underlying cause for this was identified at the time. So the patient was treated with antibiotics, but the abscess failed to heal completely, and she had persistent symptoms. The decision was then made to perform a left hemithyroidectomy for symptomatic benefit. The histology of this resected hemithyroidectomy specimen identified, surprisingly, a poorly differentiated squamous cell carcinoma of spindle cell type within the sample. So this was a very unexpected finding, and the differential diagnosis for a patient with a squamous cell carcinoma and an abscess in the left thyroid would include, first, a metastatic level 4 node which had invaded the thyroid, or level 3, which invaded the thyroid from an underlying cut primary of the aerodigestive tract and then became infected. Second, a squamous cell carcinoma and abscess within an intrathyroidal fourth branchial cleft cyst. Number 3, could it be a primary squamous cell carcinoma arising within the thyroid gland itself? Or do we have an alternative diagnosis here? Is our histology incorrect? The patient then underwent bilateral tonsillectomies and tongue-based mucosectomy to exclude an aerodigestive tract malignancy, but no cancer was identified, and a CT chest, abdomen, and pelvis was completely clear of primary or metastatic disease. So the final diagnosis in this case, based on the initial CT with a fistulous tract extending towards the piriform fossa, is a fourth branchial cleft cyst carcinoma. Fourth branchial cleft cysts typically arise within the left piriform fossa of the hypopharynx. They pierce the thyroid membrane and then descend along the left neck in the tracheoesophageal groove. They typically involve the left thyroid lobe, but may extend more inferiorly into the mediastinum and even surround the aortic arch. Suppurative thyroiditis is very uncommon, and if you see it, particularly in a young patient, it always should raise the possibility of an underlying fourth branchial cleft cyst with fistula. They are rare and represent only 1 to 3% of all branchial cleft anomalies. The most common we see is the second branchial cleft cyst. Of the 31 cases reported in the literature, 28 of all of the fourth branchial cleft cysts have been left-sided. They may be associated with ectopic or undescended parathyroid glands or congenital absence of the contralateral thyroid lobe. Surprisingly, there have been only 40 proven cases of branchial cleft cyst carcinoma in the literature to date, and none of them have ever been found within a fourth branchial cleft cyst, so this is quite a rare case indeed. However, this is a controversial diagnosis and is one of exclusion. But given the alternatives, primary squamous cell carcinoma of the thyroid gland is exceedingly rare, with less than 1%, only 3 case reports and 11 articles in the whole literature to date. And unlike our case, where our patient had complete cure with no recurrence, the squamous cell carcinomas arising in the thyroid de novo have a very aggressive behavior and respond poorly to treatment and are often radio-resistant. So our patient did have chemoradiotherapy. The right thyroid gland was left in situ, and she underwent interval ultrasound and MRI follow-up scans annually. She remains completely well with no local recurrence at 8 years post-treatment. So in summary, recurrent abscess involving the left lobe of the thyroid can herald an underlying fourth branchial cleft cyst or fistula. Any branchial cleft cyst presenting in a patient over 40 should be regarded with suspicion, and metastatic squamous cell carcinoma from the upper aerodigestive tract or arising de novo within a branchial cleft cyst, i.e. a branchial cleft cyst carcinoma, must be excluded. Okay, we're moving on to the final case. This is a case that I saw with Dr. Mucci actually in our practice here, and I hope she's present in case she'd like to discuss any other relevant clinical findings. So a 78-year-old retired IT executive presented to a specialist memory clinic complaining of memory impairment. His only past medical history included minor head trauma 15 years earlier. He was otherwise completely fit and well. Physical examination and neurological examination were normal. The only imaging available at present was a previous CT head scan performed at an outside institution, and an MRI head was requested. This is the comparative slice of the T2-weighted sequence of the MRI head and the earlier CT head study. What we can appreciate is that there is a fluid signal cyst in the left middle cranial fossa involving the left anterior temporal lobe, which extends through the squamous portion of the left temporal bone into the temporal fossa. There is partial atrophy of the left temporalis muscle at this location. This is another slice more inferiorly, and what we can identify here is that there is partial atrophy of the pterygoid musculature within the left masticator space. And a coronal T1 weighted sequence, we can appreciate that there is diffuse thickening of the V3 branch of the trigeminal nerve extending down from the cavernous sinus to the foramen ovale and then into the masticator space, there is an abrupt cutoff at this location with a dilatation of the V3 branch, and all of the masticator space muscles are atrophic on this side. So this is an unusual and unexpected finding in a patient who's completely well. The differential diagnosis for these two disparate findings, both the cyst in the middle cranial fossa and the masticator space changes, could include a leptomeningeal cyst from previous trauma or a pseudomeningocele. Could it be an atypical partially interdiploic arachnoid cyst? And in terms of the masticator space findings, is this some sort of perineural disease along the V3 branch of the trigeminal nerve from an unknown oral cavity primary? Could this be a traumatic end-bulb neuroma of the V3 branch of the trigeminal nerve, which resulted in atrophy after the patient's previous trauma? Or is there some surgical history that we're unaware of, or history of radiotherapy? The presumed diagnosis in this case, given complete absence of cancer and no history of surgery, is traumatic end-bulb terminal neuroma of the trigeminal nerve and a middle cranial fossa leptomeningeal cyst. Leptomeningeal cysts are also called growing fractures. They can occur in less than 1% of skull fractures in children, but are very rare in adults. They tend to occur when there's a dural tail with an overlying calvarial fracture. The CSF is then trapped within the leptomeninges and filled by pulsation leads to a cyst which can gradually increase in size. It may then remodel or erode the adjacent skull, protrude into the subcutaneous tissues, and be visualized or palpated as a mass. Traumatic neuromas of the V3 branch of the trigeminal nerve are exceedingly rare. Post-surgical neuromas can occur in 5 to 10% of patients undergoing complex head and neck surgery, but they tend to occur posterior to the carotid sheath or after lymph node dissection, and the nerves most commonly involved in those cases are listed here for you on the right-hand side of the slide. The Sunderland classification describes the different findings that occur after nerve injury, and we can appreciate that in neurotemnus, there is complete nerve discontinuity with a nerve gap and an end-bulb neuroma with epineural thickening. And this degree of injury, degree 5, would be compatible with the abnormalities that we've seen here on this MRI scan. The causes of masticator space atrophy in adults are quite varied, but would most commonly include trigeminal nerve schwannomas, motor neuropathies. Trauma is not so common a cause. This is just a quick revision of the anatomy of the muscle supplied by the trigeminal nerve, as well as the pterygoid musculature. It supplies the masseter, the temporalis, and the tensor veli palatini within the upper parapharyngeal spaces, the mylohyoid, anterior digastric muscles as well. So unfortunately, our patient's memory continued to deteriorate, but there were never any examination findings for focal neurology. And unfortunately, no further imaging or investigation was requested as the patient did not want to pursue it. So in summary, leptomeningeal cysts are rare findings in adults and usually occur after a history of previous trauma. Traumatic terminal end-bulb neuroma of the V3 trigeminal nerve with associated denervation atrophy of the masticator muscles is extremely rare. Nerve thickening following this injury can mimic perineural disease, a schwannoma, or post-treatment changes in patients who have had previous radiotherapy or surgery. Many thanks. Are there any questions? And I've provided some references for you. I've had to do the presentation quite quickly because I have an ultrasound list starting at 1:30, but does anybody have any questions or any comments?
No questions, but thanks for the really interesting cases.
It's a pleasure. Dr. Mucci, do you think that the diagnosis in this case is reasonable?
Hi, Jane.
Hi.
After you wrote this morning to me, I was desperately trying to remember this guy, and some snippets of the memory started coming back. I mean, it must have been quite a few years ago, wasn't it?
It was. It must have been 4 years ago. But
Yeah.
I always remembered the case because it was such an unusual case. It really stuck in my brain.
Yeah, and to answer your question, of course, I was relying on you for the diagnosis because I was completely lost and quite surprised. I've never seen anything like this in my life. So thank you very much.
It took me quite a long time to try to figure out what it was. And at first I was really worried that there was some sort of perineural disease from an unknown tumor we weren't expecting. But clinically, as you said, there was just no findings of that at all. And after a lot of research, I think I finally got to the bottom of it.
I remember you actually sent me papers back then.
I probably did.
You did, yes, you did send me papers on the subject, because sometimes, you know, when you see something rare like this, you are not sure of the diagnosis, but you might have heard of it on some conference somewhere. You sort of try to justify yourself. Is this right? Is this the correct diagnosis? And one way of doing it, of course, is getting opinions of your peers, but the other way is finding as many papers as you can, reading through the subject, and before you know it, you become a world specialist in it.
That's brilliant. Thank you so much for the incredible case. It's really good.
Thank you.
I'm going to nip off to ultrasound if nobody has any other comments or questions. And I hope everybody has a great day.
Bye.
Bye-bye.
Thank you.